Welcome, everyone. Welcome to the University of Toronto Joint Centre for Bioethics Seminar Series for the 2022-2023 academic year. My name is Sophie Rohr, and I'm a PhD candidate in public health at the University of Toronto. And it's my pleasure to be moderating today's seminar. Today's speaker is Sydney Campbell, who will be presenting on death and dying in childhood, a silenced phenomenon. The format of today's seminar is a presentation by our speaker, followed by a moderated discussion with the audience. The seminar is being recorded and will be posted on the Joint Centre for Bioethics website, where you can also find archive seminars. Before I introduce Sydney, I wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous peoples from across Turtle Island, and we are grateful to have the opportunity to work on this land. Now it is my pleasure to introduce today's speaker. Sydney Campbell is a PhD candidate in the Institute of Health Policy, Management and Evaluation at the University of Toronto, and simultaneously completing a collaborative specialization in bioethics through the Joint Centre for Bioethics at the University of Toronto. Her doctoral research focuses on generating normative and empirically informed evidence to advise future policy discussions concerning MAID for mature minors. As a whole, her work aims to advance perspectives on childhood well-being, children's rights, and policymaking related to young people's healthcare. Sydney has also won the 2022 Larry Liebrich Prize in Ethics and End-of-Life Care Award. And this award recognizes excellence in a completed scholarly work that demonstrates originality, relevance to ethics and end-of-life care, and actual or potential impact on the field of end-of-life care. Welcome, Sydney. We look forward to your presentation.
Thank you so much, Sophie. And thank you everyone for joining today. I'm Sydney, and as Sophie said, today we are going to be discussing the concept of death and dying in childhood, and particularly the unspeakable nature of this topic. Throughout today's discussion, I will use the words children, youth, and young people interchangeably, always referring to anyone under the age of 18. And I just want to take a moment to remind everybody that the topic of today's discussion is obviously one that's sensitive and may trigger an emotional response. So I just want to encourage folks to listen to their mind and body and take breaks when and if they need to. This session is a time for thoughtful and meaningful reflection and dialogue, but it can also be a time just to listen and join that way too. So I'm grateful for everyone joining today in whatever ways you feel best. So the topic of today's session is obviously about death and dying in childhood. Death and dying are sensitive and often highly personal matters. When we think or talk about death of a loved one, especially if we're acutely aware of what this experience is like, we know that it can be a painful experience in which there may be no words to explain. But with the death of a child in particular, the experience is heightened and really considered unspeakable. This may, at least in part, be due to the fact that the death of a child betrays the natural order in which children are thought to outlive their parents and caregivers. And so it makes sense that the discussions may become unspeakable in that this may be a response to the trauma of that experience. In addition, the advances of modern medicine and public health have led to improvements in child health and overall declines in the childhood mortality rate over the past 100 years. And as such, children's deaths comprise a relatively small percentage of a country's total mortality statistics. So for instance, in 2015 to 2019 in Canada, childhood deaths made up an average of about 1.1% of the total amount of deaths per year. And so sometimes the pain of this experience, compounded with the fact that there's a relatively small percentage of children who comprise the country's mortality statistics can lead to childhood death and dying becoming unspeakable or silenced. Despite these contextual factors, the small percentage of children who do die every year and the individuals who are left to deal with that loss represent real individuals who are living with these experiences. And yet, so many claim that discussing death and dying is too challenging to think about or talk about, resulting in childhood death and dying becoming a silent social, cultural, psychological, and spiritual phenomenon. And this was a topic that was a catalyst for the paper written by my doctoral committee and co-authors that I'll be sharing reflections from today. To set the context, my doctoral research focuses on, as Sophie mentioned, pertains to medical assistance in dying or MAID for mature minors in Canada, and it particularly aims to generate ethical and empirically informed policy recommendations to inform decisions related to MAID for mature minors in Canada, which is currently not legal in Canada. I entered the PhD with a passion for talking to and with young people and hearing about their thoughts on MAID and their healthcare experiences in general. However, a common thread early in the planning of my research was the perceived unspeakability of childhood death and dying, with silence being an accentuated feature of these discussions, particularly silence on the part of young people. And so this led to a question that's really foundational to my work. Should we be talking to young people about death and dying in childhood? And fundamentally, answering this question involved examining what the unspeakable nature of death and dying is like, namely, what is unspeakable, what the nature of the phenomenon is like, and the concerns that are maybe associated with this phenomenon. And today we'll also be discussing some next steps. Before diving into the analysis, I just wanted to return to this slide and highlight the foci that the authors, including myself, brought to this paper. Beyond what I mentioned in my PhD work, we are a PhD candidate in health service research, a professor, research scientist, and psychologist under training who has experience in qualitative and arts-based methods, a philosopher and health policy ethics scholar, a scientist and executive working at the intersection of technology and healthcare delivery, and a pediatrician who cares for young people with chronic diseases, and a scientist focused on the ethics of health policy decisions. So this just gives a bit of insight into the lenses and the experiences that we brought to the paper. And so in today's session, we will examine this phenomenon as described in the paper. I'll start by defining the disciplinary lens that was used for this work and key concept. We move on to exploring what the unspeakable is and the potential reasons that this phenomenon arises. I highlight the perceived tension between hope and death and some ways to reframe this tension. I also indicate the harms that might be associated with death being silenced in childhood, and finish up by describing some key takeaways. So for this paper, Principles from the Sociology of Childhood informed and facilitated our thinking. For our work, we understood childhood to be a social construction wherein the meaning that's attributed to childhood varies across time, space, and culture. Sociology of childhood scholars challenge dominant models of childhood that were initially advanced by developmental psychology. And in these views, children are in the sociology of childhood, children are recognized as possessing competency, capacities, and autonomy, having interests of their own, and as agents with rights. We're critical of views that employ a stage-like view of children and childhood, particularly for those with medical complexity and critical or complex illnesses that disregard what young people can and will do, or what they wish to do. To be clear, the issue and the gaps that we highlight isn't with developmental psychology in particular, but rather with the teaching of outdated methods of understanding childhood and children. So in addition, sociology of childhood also acknowledges the relational nature of childhood and of children. It does so by highlighting the ways in which children are influenced by their social circles and contexts, and also the ways in which they influence their social circles and society at large. In the context of this paper and today's presentation, sociology of childhood helps us to frame how we position children and childhood in these discussions and in the context of childhood death. And our ideas for next steps, which really relates in particular to the tension and the reimagining of hope and death, and the harms that we perceived and the reasons that these harms exist. So moving on to defining this key concept that we're talking about today, the unspeakable nature of childhood death. What we define this as in the paper is a phenomenon in which the entire end-of-life experience of a child or youth, also encompassing the time leading up to and following a child or youth's death, is made silent for the young person themselves. But also not just for the young person, but for their family, their friends, and other members of the child's social circle, for clinicians, for researchers, and for society more broadly. Here, silence refers to the lack of discussion, deliberation, and dialogue that occurs regarding the young person's death and dying experience. It does not include the ability to think about one's death by oneself, or the necessary conversation that occurs between clinicians and family members regarding prognosis and end-of-life decisions. And we make this distinction because a lot of literature does highlight that even in cases where a child is not explicitly informed about their death or having a terminal illness, they are still thinking about that possibility in a lot of cases. So we don't exclude that as being silenced, but really about the dialogue that comes around with their dying experience. And we say this silence arises both clinically and conceptually. By this, we mean, first, in a clinical regard, our interactions with healthcare practitioners and researchers, we've heard about the hesitancy to discuss death and dying that families reveal in clinical interactions, particularly when a child is towards the end of their life. And this is based on the assumption that these types of conversations are troubling for children. And the result is that there's silence about death and dying at the bedside. And then from a conceptual standpoint, there's also very limited research on how childhood death and dying is theoretically or conceptually understood by children, families, and by society. Further, there's even less academic dialogue on how such silence is innately linked to death and dying in the context of childhood, around that notion of silence. And this is despite critical policies that have been put in place around the world relating to the deaths of children, whether it's in regards to pediatric palliative care, other understandings of death, and in the context of my research, where this kind of idea began with regards to medical assistance in dying. And there, from our understandings, appear to be two core reasons that contribute to this climate of silence on childhood death. The first, the dominant ways in which death and dying have previously been conceptualized do not fully encompass or always encompass death and dying experiences during childhood in particular. These dominant frameworks support an assumption that conversations on death and dying are too challenging for children to tolerate or understand, and also that such conversations will lead to further undue harm onto children. So these dominant models, as the slide shows, include the Western interpretation of death, which is informed by Christian beliefs and principles most prominently. And according to this view, death is seen as a personal transformation rather than a loss. There's also the medicalized notion of death and dying, which is based on anatomical terms. This includes understandings related to brain death or cardiorespiratory death, and models of that sort. Both of these views position death as distasteful, bad, or negative, and they also don't consider the person, the actual person experiencing that loss, who's centralized in this death experience, and what differences might exist for children in particular, whether anatomically, spiritually, psychologically, etc. Oh, sorry. And then we have the Kubler-Ross view of model of dying. It's a 5-stage model, and it's from a highly cited and controversial work written by KublerRoss. Although it's not necessarily a way of understanding death, it is meant to describe what the process of dying can be like for those either directly or indirectly experiencing death. The 5 stages are denial, anger, bargaining, depression, and acceptance. These stages are said to not be linear, so it's possible to move amongst the 5 stages in any particular order, and it's also possible for 2 stages to exist at the same time. However, as Kubler-Ross has actually mentioned, these stages might not actually map onto the way dying is experienced for young people and their families because the models are based on adults. One factor that indicates this is that this model and the 5 stages involve an assumption wherein the knowledge of death is ensured amongst all parties, and where acceptance is an achievable or intended state of coming to terms with an impending death. In particular, there's a lack of social acceptance around childhood death and dying in the same way that which is different from what happens with adults in a lot of cases. And while this is entirely understandable, given the general social and biologically ingrained interest to protect children at all costs, the result is really that childhood death becomes unspeakable and silenced. Moreover, this silence is cyclical, where the silence is both a result and an additional mediator, such that the lack of social acceptance perpetuates avoidance of the topic of childhood death and a lack of social acknowledgement, not even social acceptance. And this lack of social acknowledgement can also undermine the possibility of personal acceptance on the part of young people and their closest inner circle. And this notion of lack of personal acceptance really does go against the view that was advanced by Kubler-Ross. And on the right of the screen, I just want to highlight this painting by Edvard Munch, which is called The Sick Child. It depicts Munch's older sister, Joanne, who died from tuberculosis at the age of 15. And on the far right, you'll also see an older female relative, which is thought to be Munch's aunt. I thought this painting was very interesting and also relevant because it kind of depicts the process of dying that is experienced by a young person who is really consoling, in this case, their older relative, despite being in the process of dying. I thought the painting is said to reveal the impending death by the black curtain that's on the very far side of the painting. And there's also silence in the room. You see the aunt looking down, not at Joanne, and yet a joint acknowledgement of Joanne's impending death. So in a lot of ways, this kind of painting indicates the silence that's really ingrained in society for so many years. And then the second notion or reason that contributes to this climate of silence, from our understanding and from what we discussed in our paper, is the positive health outcome, which is longer life expectancies and better prognoses amongst children with underlying illnesses. Childhood and infant mortality rates are said to be a key measure of the health of a society. Over the last century, there have been significant reductions in the global childhood mortality rate. So for instance, in 1960, the global childhood mortality rate was around 19%. And in 2017, this dropped to around 4%. And many believe that the medical advances of the 20th and 21st century have contributed to declines in childhood mortality rates. Others believe that a recognition of the importance of social determinants of health also contributed to things like an increased standard of living, and this reduced, in part, childhood mortality rates as well. This also aligns with statistics indicating differential mortality rates amongst children based on race, ethnicity, family income, gender, and other key factors. But overall, these incredible improvements in children's health and reductions in their morbidity and mortality rates have had the unfortunate byproduct we hypothesized in the paper in resulting in conversations about childhood and death and dying being almost entirely lost from the vision of most societies, and silence being propagated. In other words, when discussions about sensitive topics like childhood death can be avoided for the majority of a population, the status quo is that silence will result on the topic. And we just want to reiterate that, I want to reiterate here in this forum that it's crucial to acknowledge that there are disparities in childhood survival and health around the world, and there's very little known about the impact that these disparities can have on the understandings of death and dying in childhood. And so for next steps, it's, as I'll highlight later on, it's crucial that we think about and understand how death and dying are conceptualized or confronted differently based on the context and the norms that are at hand. So moving on beyond these two reasons that contribute to this climate of silence, to examining how the narratives of death and dying can become overlooked or trivialized. And it becomes important to understand where the fundamental rejection of childhood mortality lies, or conversations about childhood mortality, and why this rejection or disregard exists. In my own research and the work of my colleagues, something that's been persistent that we've noticed is an emphasis on hope's inherent value and functionality in pediatric care settings. So in this paper, we decided to dig into that and understand whether there's any possible contribution to an avoidance of topics related to childhood death and dying. Firstly, hope is fundamental to how most societies envision childhood, and this can be associated with narratives that came out of World War II, in which children and childhood were seen as a symbol for the future and a symbol for the reconstruction of society. Hope has importance for children that are experiencing an underlying condition and for their families. It helps families and young people to cope with news and diagnoses they receive, particularly if they're unpleasant. It may also play an instrumental role in supporting young people to persevere through negative side effects of treatment or the negative impacts that their illness may have on their lives. In pediatric care, the notion of hope is said to be mainly curative in nature. And this is where conversations about death and dying become challenging. Since hope is seen as mainly curative in a pediatric context, or built around this curative nature, conversations around death and dying are often seen as a threat to the hope that's been built throughout a strong family-clinician relationship and also throughout a child's illness. So as such, the standard pediatric clinical environment, although wonderful and very supportive for families in a lot of cases, can make it challenging for hope and death to coexist. Thereby, this reproduces this problematic binary, the binary and the tension that if death is not a likely outcome for the patient. And this can lead to also, aside from the avoidance of conversations at the bedside, a dismissal of the importance of research conversations on childhood death and dying, which again may be seen as problematic due to the way that pediatric care is formulated and a need to not get into the topic of childhood death and dying, even in research environments. So by extension, this notion of hope that comes into tension with death indicates that hope is really inherently tied to life, and by extension is in opposition with the notion of death. Yet for some individuals, hope for a cure can be reformulated and re-envisioned into hope for other things. And this can happen through dialogue related to death and dying. This might include, for instance, hope for a greater quality of life, hope for a sense of normalcy, hope for love and relationships, hope for reduced suffering, and more. Hope and likewise death can be similar to the image of the glass half full in this picture, whereby there's different ways of understanding it and engaging with this notion of hope. Moreover, children, parents, or caregivers, and even clinicians can simultaneously hold hope for unrealistic expectations about prognosis, particularly if a child has a terminal illness, while acknowledging the realities of the children's illness progression. These are not mutually exclusive. So in other words, hope for a cure can be maintained even in the case where that's an unrealistic expectation, and parents and families and children are still in recognition of their realities that they're facing. As mentioned at the top of the slide, this first point, not everybody has to have the same way of understanding hope. And the sociology of childhood encourages us to consider this in the dialogue we share with children. And children may be experiencing and expressing themselves in different ways. And we should use this to support children with critical complex illnesses or chronic illnesses and their families to define what hope means for them, how hope or their vision of hope may change across time, and to understand if engaging in conversations about death and dying can be part of or is part of their vision of hope and how they wish to define what they are hopeful for. Approaching the end of a young person's life does not necessitate the cessation of care. It also does not necessitate the cessation of hope. Instead, dying and death in childhood can be redirected and can redirect the conversation to allow for an embodied emotional and spiritual experience of childhood illness or a critical illness, and allow this to be brought into the space that is focused on balancing reasonable expectations and realities with feelings and wishes of wistfulness and fear. Yet children are, on the whole, holistically removed, in some cases, some may say spared, from these conversations about death and dying, both in the clinic and in research, which allows this problematic binary between hope and death to remain undisputed. This binary and this notion of the unspeakable nature of death and dying can in fact lead to additional harms that impact not only the young person, but also their family and social circles. First, young people have rights, and according to the UN Convention on the Rights of the Child, UNCRC, to be involved in decisions that impact their lives. And according to Article 12 of the UNCRC, they should be included in these decisions as a matter of right. When silences result, however, particularly silences around death and dying, whether this happens with good intention or not, these rights can be overlooked. And this is an infringement on children's rights. This is an additional harm that children are facing beyond the harms mentioned with regards to not being included in these conversations. The second point that's raised here is that avoiding conversations about death and dying with children and young people can also be a trigger for new issues to arise. So for some young people, and there's research to indicate this, not being able to talk about their death, or even if it's not a prognosis that they've received, not being able to talk about death in general can lead to a sense of loss of control and can heighten anxieties that already exist for the young person about their future or the futures of their loved ones. And this also aligns with literature on disenfranchised grief, in which grief is not able to be expressed, and this leads to heightened impacts on the young person in this case. And finally, a lack of discussion around death and dying, even if it may be for protective nature of parents protecting children, it can actually lead to impacts on parents and caregivers themselves. In one study with bereaved parents of children with severe malignant diseases, parents who did not talk about death with their child who had a terminal illness did voice regret. So those who did not talk about death did voice regret, and that was 27% of the parents that responded. Whereas parents who did talk about death with their child did not voice any regret of the sample that was included. And so this indicates the harms that can happen to young people, to young people and to their parents and caregivers in cases where they're either made aware and not able to talk about it, or in which they're not made aware at all. And approaching the end of a young person's life does not have to lead to these harms. If we frame conversations according to sociology of childhood around what death and dying look like, even again, if it's not necessarily something that is impacting a particular young person, but maybe somebody in their extended family, these conversations can have meaningful impacts for young people. So some key takeaways from today's discussion, and then I would love to open up give some time. I think we have still a lot of time for discussion, which is great. So really, where do we go from here with knowing that understanding this unspeakable nature of childhood death and dying, with this acknowledgement of the associated harms and tensions that exist and ways to reframe those tensions, and with a recognition that there is a need for next steps. So as mentioned before, it's really crucial to understand the role that context, culture, and societal norms plays in impacting how childhood death and dying are understood and conceptualized, and also how they're confronted at the bedside and in homes. In our paper in today's presentation, the focus was on high-income countries with this westernized view, particularly because we're located in Canada, thinking about this from a Canadian-US perspective. And there's not much that we know about other countries and other cultures' interpretations. And despite knowing very little from these perspectives, we know even less from other cultures and countries. So some suggestions for how we can implement a project that looks at this and looks at the impact of culture, context, and societal norms. The first is potentially using a historical document review to understand whether historically there's any literature that pertains to the conceptualizations of childhood death and dying, and the degree to which there's openness to the discussions around childhood death and dying. And the second way to do this is more engaged with a qualitative approach in which we're developing an anthological or cross-cultural study to explore this unspeakable phenomenon by meeting with young people, their parents, their clinicians, understanding how death and dying are conceptualized, understanding whether silence is propagated through conversation or lack of conversation, and what next steps may exist. In addition, new research must challenge this discourse by engaging with young people, particularly those that have lived experience of an illness, to understand how death and dying are understood and confronted, and how this silence is confronted related to childhood death and dying narratives. There already exists definite exceptions to this phenomenon because there are many clinicians who utilize non-essentialist approaches and tailor conversations with the young person that they're meeting with and with their families. But on the whole, there is widespread avoidance of these discussions at the individual, research, and societal levels. And this still exists and has downstream impacts, as we've discussed today. And finally, this tendency to treat all young people as a uniform group is informed by outdated models of childhood and of children, as mentioned earlier. And this needs to be challenged through critical approaches that recognize the capacities of young people to engage in conversations, whether that's related to death-related conversations in particular, or other types of conversations, to uphold these rights and treat young people and their interests as things that matter. So I would just like to acknowledge and thank my committee members and co-authors for their contributions on the work, and to the Social Sciences and Humanities Research Council of Canada for funding this work, references, and there's my contact information.
Wow, thank you so much. So it's now time for questions and discussion. And if you have a question, please put it into the YouTube chat. If you aren't logged into YouTube or you wish to ask a question anonymously, you may also send your question to jcb.ea@utoronto.ca. That email address will be posted in the chat for those of you who are joining through YouTube. So Sydney, I want to thank you for a tremendously interesting talk. And as questions begin to come in from the audience, I wonder if I might kick things off with an opening question. So I'm interested in what it would look like in practice to start the conversation around death with this new framed hope. So in other words, how do you start a conversation around death with children? What would that look like?
Yeah, this is a great question. Thank you, Sophie. I think it's interesting because there's also kind of two types of answers to this question, depending on what type of conversations we're talking about, right? So again, because we formulate the gap and the silence as having two prongs, clinical and conceptual, or clinical and really research-based, we need to think about the conversations maybe differently in each setting. And maybe I'll start with the literature side, because that's what I'm most familiar with, being doing my PhD. We first need to kind of understand what what's missing from young people's perspectives. And I think one way to do this is really working with those who have experiences, firstly, raising conversations of death and dying with young people, not necessarily childhood death and dying, but death and dying more broadly. So bereavement counselors, or even parents, as I mentioned, those who have had these conversations, understanding from their perspectives how these conversations were launched with young people when they needed to have tough conversations, and what was meaningful in those interactions, to understand how we can, moving forward in a clinical or research setting, engage meaningfully with young people. The other part of this is really because from my own experience doing research related to MAID with minors, the other part becomes a conversation with those who are kind of upholding the ethics standards, to understand from their perspective also how we can continue protecting participants, in this case, young people, but also engage in these conversations at the same time. So I think a lot of times, again, there's this fear that when we engage young people, it's going to heighten the risk that the participant is facing. And obviously, as an extension of that, that would make it more ethically cumbersome or problematic, and a lot more would need to go into addressing this. And of course, I'm not suggesting that we get rid of all these ethics standards altogether, but really like working with young people and those who have had these conversations, and ethics boards, to understand, again, how to move forward and have these conversations, but so that we don't prevent conversation and perpetuate silence, but also obviously need to have protection in place so that nobody faces undue risk. In my research, we, for instance, in engaging with young people around conversations that may bring up death and dying, we provide a list of mental health resources for young people who, in case they were to face some type of problematic emotional or psychological outcome after having the conversation. And so that might be one way of engaging with young people, like really recognizing the risks, recognizing what they want to speak about and what has been meaningful in the past, and then using this information to inform clinical training, which really has impacts at the bedside. And I think also engaging parents to build rapport is another really key piece, because this obviously has impacts onto what young people are able to talk about and who consents to these discussions, but also because, as I mentioned, young people are relational in nature, and their parents are going to support them and be with them, caring with them if these conversations do come up. So there needs to be a way to balance, again, this protection with the need to move these conversations forward. I hope that answers.
Yeah, that's really interesting. And I guess on that note, I'm wondering, can you tell us a bit more about the work that you're doing now, and how that project kind of connects to this paper?
Yes, yeah, absolutely. so at the beginning, I highlighted that my doctoral work kind of focuses on medical assistance in dying, or MAID, for mature minors in Canada. And it does aim to provide ethically and empirically informed recommendations. So in that work, I've been aiming to discuss with parents and caregivers and with young people themselves around their thoughts on MAID, and their thoughts MAID in general and MAID for mature minors, which is, again, not legal in Canada, but what their hopes, aspirations, and interests are with relation to this policy. And so it connects to this project because in planning for the research, a lot of times something that was brought up is, oh, we can't engage in those conversations because we've really built a lot of hope with young people, and even though they can't access MAID and it's not something that's on the table for them right now, the mention of death, sometimes it was the D word is what it was called, is really going to be problematic. And I sympathize with that. I think in a lot of ways, there's the underlying concern there is a fear around young people's well-being. And of course, that's understandable and commendable that there needs to be that protection. And yet at the same time, we see that not engaging with them in relation to MAID leads to the policies really being built by only adults, even on surveys and things that have not been structured with childhood scholars and with children in mind. There's no engagement with young people, even adolescents or youth, around what their hopes are. And this is really problematic because they are still stakeholders with regards to these conversations, because they still have the possibility of dying. And it's important to kind of have conversations around what people, including young people, are hoping for, what their interests are, so that when we develop policies, they can really be representative of society at large instead of a subset of that population. So I think that is really the broad way that it connects with today's discussion. But obviously there's so much more. So
thank you so much. And there are a few questions in the chat here. So Jessica Dowden said, hello, Sydney. Thank you so much for your presentation. Is there an age demographic that you found to be ideal to start this type of conversation with?
Yeah, I love this. I love this topic and this question around age, because in a lot of ways, even in the sociology of childhood, who really decentralizes the notion of age instead moving to competence and capacity, there is still a recognition that, biologically, age is a factor. So we wouldn't say, for instance, that a 2-year-old is going to be having, or it's useful to have the same conversations with a 2-year-old as it would be for a 14 or a 17-year-old. So I think, that we can change conversations and the way in which we convey topics, in which they can be meaningful with really any young person that's able to communicate, and in their own way, whether verbally or through art, or through like drawing pictures, and making stories. So there's different ways to engage in these conversations, even if it's not a verbal conversation. So I wouldn't say necessarily that age it impacts whether we should or should not have these conversations, but more age might dictate the ways in which we're framing these conversations and how the conversation takes place, and what tools and instruments we might use to engage young people in conversations, and what emphases we might make. So for instance, we might really focus on agency and what a young person that's 16, what their hopes for the future are, and what their interests for the current time are if we're engaging them in conversations around their own death. Whereas for a 2-year-old, we might instead focus on what interests them, what they're looking forward to. And we can do that through all these different means that are available. And I think in childhood scholar literature, childhood studies literature, there's so much that we can learn in terms of how to advance the conversations in different ways for different young people.
So interesting. So there's another question that relates to some of the kind of structures that maybe the institutional structures around these conversations. So Victoria Wang says, thanks. I wonder how the non-staged, more contextual view of childhood can be put into practice in a medical setting that often relies on protocols. So for instance, to do this for 2 to 5-year-olds or 5 to 10-year-olds.
Yes, yes, absolutely. I think at present, because there's such a gap in the conversations, it becomes important. Again, this kind of goes back to your question, Sophie, around how we can start engaging in these conversations. And fundamentally, I think it's important to understand how information from other conversations not related to death and dying can inform conversations around death and dying. So we have so much literature around voice and engagement and participation with young people in care settings. And the connection really needs to be made in terms of how does that apply with relation to death conversations in particular. So what's different about a death and dying conversation? What needs to be emphasized in those conversations, and in what contexts, and for whom? So I think that comes back to this person's comment around, again, coming back to this stage model and how that's kind of fundamental to the way pediatric care is facilitated. So we might actually need to engage parents more in these conversations and, allow them to give them the tools to have the conversations with their child, if that's kind of in the family's best interest. And it comes back to this notion of best interests and recognition of the child as a person, as somebody with their own interests. Even a very little child has their own interests, and that's what sociology of childhood teaches us, that we need to engage in those interests and recognize the young person as a person with rights. And the way that that's mobilized based on the institutional setting might look differently in terms of how much parents are involved, like the emphasis on the relational nature of the child, the emphasis on the tools of communication, as I was mentioning before, and but also obviously needing to abide by the policies of the institution itself, and working with the policy makers, whether institutionally or in government or something like that, to facilitate that in a way that's effective and aligned with the goals of the institute.
So there's a question that kind of, I think you kind of touched upon in terms of the differences between adult and childhood MAID. And so Sagni Kuma said, thank you, Sydney. I was wondering if conversations regarding death would differ between cases of MAID versus unassisted death among children. So are there legal implications in these situations? Maybe you can clarify that.
Definitely. Yeah, I think in the MAID literature, a lot of the focus around these legal implications is who initiates the conversation. So that might be something that's different in MAID conversations. Again, MAID is not legal in Canada for minors. But when we look to, for instance, the Netherlands or Belgium, where MAID for minors is legal, the conversations again have pertained to who initiates the conversation. Is it the clinician that offers all of these options to the young person? Is it the young person that comes to the clinician and asks for assisted dying in particular? And the implications of that are, again, I think there's a suggestion that the clinician might have some pressure that's put on the young person if they're the one that's suggesting it, as opposed to other end-of-life conversations where that might not be perceived the same way because the clinician is kind of removed from the dying process, whereas in MAID, the clinician plays a central role in facilitating the person's death. So that might be one area that requires some legal clarification around, okay, we are in these, if MAID were to become legal in the future, who's going to initiate the conversation? And based on the legal implications. So that might be, I think that's one difference. And another difference might also be, again, this notion of parental involvement and safeguards. So in relation to MAID in particular, in other countries, there are a lot of extra safeguards that are put in place. So, for instance, a young person in the Netherlands must have a psychological assessment completed before they can request or receive MAID. And that means that a psychologist, a clinician, like their primary caregiver, and sometimes a second primary caregiver need to make sure the young person's capable of making that decision. And there's similar processes that happen with relation to making an end-of-life decision for young people in Canada, not MAID related, just an end-of-life decision that's not assisted. But this emphasis on the safeguards is really prominent in MAID literature in particular. So that might be another area where there's this difference that exists.
And we have time for one last question, and all of these questions will be forwarded to Sydney, and her contact information was available on that last slide and will be shared in the chat. So if anyone wants to follow up with Sydney directly, they're welcome. I believe they're welcome to do that.
Yes.
So Lucy Turner, she wanted to ask, I wonder if there's any scope for involving the siblings of young people who are dying or have died. I'm sure the grief process is complicated for these children in the context of this silence.
Yes, this is a really great point, because I think it touches on silence in a different way that I've been kind of discussing it today. So primarily the discussion today has been on a young person with an underlying illness who's not able to talk about their own impending death or their own death and dying experience. Whereas I think this question is more so focused on a sibling watching their own sibling going through a death and dying experience, having this kind of double silence where it's not talked about by their sibling. Maybe it's also not talked about by them because they are a young person. And I think that this is really important, not just for grief, but also just for facilitating an understanding of how death and dying is really conceptualized by young people, even when they're not the ones that are facing the impending death. And so for that reason, I think it's like pretty crucial that we engage siblings in these conversations in meaningful ways as well. And I think child life specialists offer some scope into how we can engage siblings. And coming back to an earlier question around how to engage young people, I think also young people that might themselves be dying in these conversations. I think that child life specialists can offer some insight into that, because they work with young people facing illness and throughout their illness trajectory, and really understand what might be needed by a young person at a particular time. And I think with siblings as well, there might be different needs. So communication might, again, need to happen differently for a sibling compared to the young person that's experiencing the experience directly. But they're still experiencing the death indirectly as an observer and as a member of their siblings' social circle. So again, yeah, that's a great question. And I think the conversation is pretty crucial from that side as well.
Well, it's time to draw today's seminar to a close. And before I thank our speaker, I have a couple of announcements to make. Our next seminar will take place on Wednesday, December 7th. Alyssa Izzat, Rebecca Greenberg, and Nipa Chauhan will be discussing ethical considerations for sterilization refusal in nulliparous women. To sign up to receive our weekly email reminders about JCB seminars, or to be added to the distribution list for the JCB Events Digest, please email jcb.info@utoronto.ca. And this email will be in the chat. Sydney, on behalf of all of us, thank you so much for your presentation and the insights that you shared today.
Thank you, Sophie. I appreciate it.
Thank you, everyone. I hope you have a wonderful evening.
Bye.